high-quality medical and surgical care rendered during the past 2 decades to infants and children with congenital heart disease has resulted in survival of these patients into the adulthood. Accordingly, an increasingly large number of adolescent and adult patients with various forms of congenital heart disease are being seen by the adult cardiovascular specialists. Since echocardiography plays a vital role in the complete assessment of these patients, therefore it is crucial that the adult cardiologist be thoroughly familiar with the echocardiographic features of various congenital lesions. In this tape, we will present and discuss the role of two-dimensional echo, pulsed and continuous wave Doppler, as well as color flow imaging in the diagnosis and hemodynamic assessment of various forms of congenital heart lesions. The types of lesions seen by the adult cardiologist usually represent one of the 3 categories. Firstly, patients who have undiagnosed defects. We still see a relatively large number of adult patients with undiagnosed acyanotic lesions. The most frequent lesions include various malformations of the aortic valve, such as bicuspid, unicuspid, and quadricuspid valves, atrial septal defect, pulmonary stenosis, subaortic membrane, and rarely Epstein's anomaly. The 2D echo diagnosis of congenitally malformed aortic valve has been discussed in tape number 4. The other lesions listed here will be discussed in detail later in this tape. The next category represents patients who have had palliative procedures performed at a young age consisting of aoropulmonary shunt, such as Blalock Taussig anastomosis, or had pulmonary artery banding. These patients come to medical attention in their adult life either because of failure of the shunt or other related complications of cyanotic heart disease. The third category represents an increasingly large number of referrals to the adult cardiologists of patients who have undergone complete repair at a younger age. In this regards, it is worthwhile to note some of the milestones in repair of congenital heart defects. In 1938, 50 years ago, patent ductus was successfully ligated, while in the early 50s, atrial septal defect and ventricular septal defect repair was accomplished. In the mid-50s, tetralogy of Fallot and double outlet right ventricle were successfully repaired, and in 1971, Fontan operation was performed. It is important for all of us to remember that other than closure of patent ductus arteriosus and suture closure of an uncomplicated atrial septal defect, all other operations designed to accomplish complete repair certainly have significant residua as well as significant sequelae. We will first discuss the 2D and Doppler features of acyanotic lesions, followed by discussion of a systematic and segmental approach for evaluation of patients with cyanotic as well as complex lesions, and finish with evaluation of post-operative congenital cardiac. The acyanotic lesions can be further subdivided into 2 categories: the shunt lesions and the stenotic lesions. Shunt lesions are atrial septal defect, partial anomalous pulmovenous connection, ventricular septal defect, and patent ductus arteriosus. Let us begin with atrial septal defect, which is one of the most common forms of congenital heart lesion seen in the adult cardiology practice. The 3 most common forms of atrial septal defects are ostium secundum, ostium primum, and sinus venosus types. Before discussing each individual type of ASD, we would like to emphasize that for a complete examination, the atrial septum must be scanned from many different ultrasound windows as are listed here. The subcostal window is particularly important since from this approach the ultrasound beam can be directed nearly perpendicular to the atrial septum, and hence the defect can be confidently visualized. False positive dropout in the region of the fossa ovalis is a frequent problem when the atrial septum is imaged from the apical or para-apical positions, as well as in the parasternal short axis view. In patients with enlargement of right-sided chambers, the right parasternal window can also provide excellent visualization of the atrial septum. Recently, transesophageal echocardiography has provided a new window to the heart, and in particular to visualization of the atrial septum. Proximity of the esophagus to the atria provides high-resolution images of various atrial septal defects and even permit visualization of patent foramen ovale. This, as well as subsequent anatomic slides that will be shown, are provided with courtesy of our cardiovascular pathologist, Dr. William Edwards. This is the typical appearance of secundum atrial septal defect. We are looking into an opened right atrium and right ventricle. For orientation, this is tricuspid valve, and here is coronary sinus, inferior vena cava, and the entrance of superior vena cava. This is the limbus fossa ovalis. A large ostium secundum type of ASD is present in the fossa ovalis membrane. Let us now look at 2D and Doppler examples of ostium secundum ASD. This is parasternal long axis view demonstrating typical features of right ventricular volume overload. The right ventricular cavity is dilated, ventricular septal motion is abnormal, and left ventricular size and function is normal. Note normal coaptation of mitral leaflets with no prolapse. This is parasternal short axis view. Note again that the right ventricular cavity is moderately enlarged, while the left ventricular cavity is of normal dimension. In real time, features of right ventricular volume overload are again evident. This is parasternal short axis view at the base of the heart. This is aortic root, aortic valve. Note that the right ventricular outflow tract is dilated, as well as the pulmonary annulus. In real time, note the normal motion of the pulmonic valve and dilated main pulmonary artery as well. This demonstrates the color flow examination. In real time, note the laminar flow in the right ventricular outflow tract and slight degree of pulmonic regurgitation. This is a low parasternal four-chamber view with apex down orientation. This is right atrium, right ventricle, and the left-sided chambers are here. Mitral and tricuspid leaflets are in normal closed position. Note a large dropout of the atrial septum as seen in this particular view. In real time, note the normal motion of mitral and tricuspid leaflets, the dropout of the atrial septum, and dilated right heart chambers. This is the still frame of a color flow examination in the four-chamber view format. Note here this large bolus of flow directed towards the transducer encoded in colors of red, which represents the shunt across the atrial septal defect coming from the left atrium to the right atrium. Watch this in real time now. This is subcostal examination. This is left atrium, atrial septum, right atrium. Note there is a large defect in the mid portion of this atrial septum. The lowermost portion of the atrial septum is intact, as is the uppermost portion of the atrial septum. This is the entrance of right inferior pulmonary vein normally into the left atrium. This is a freeze frame of color flow examination. Here we see a large bolus of flow directed from left atrium through this atrial septal defect entering into right atrium in this position. Observe this in real time now. We have now placed a pulse Doppler sample volume in the region of the shunted flow across the atrial septal defect. This will demonstrate in real time the characteristic audio as well as the spectral pattern of shunted flow across the ASD. This freeze frame demonstrates the characteristic spectral profile of the shunted flow. Note that the left to right shunt commences during end systole, is holodiastolic, and there is further accentuation after atrial systole. Note also that this is a turbulent flow pattern. This is low parasternal four-chamber view. This is right atrium, atrial septum, left atrium, left ventricle, and this is a markedly dilated right ventricle. Note also that the right atrium is moderately enlarged, and a defect in the mid portion of the atrial septum can be visualized on this frozen frame. The left-sided chambers, in particular the left ventricle, appears of normal dimension. In real time, the features of right ventricular volume overload can be appreciated, as well as the defect in the mid portion of the atrial septum. This is the still frame of color flow examination. Note large bolus of flow encoded in red entering into the right atrium through this atrial septal defect extending from the left atrium into the right atrium. This is the subcostal examination of the atrial septum. This is left atrium, atrial septum, and right atrium. Note that the defect in the mid portion of the atrial septum is clearly visualized in this format. The lower portion of the atrial septum as well as the uppermost portion of the atrial septum are intact. The right inferior pulmonary vein is entering normally into left atrium in this position. This is the still frame of a color flow examination, demonstrating again a large bolus of red encoded flow into the right atrium across the atrial septal defect. Guided by the flow image, we have now placed a pulsed wave Doppler sample volume in the right atrium in the area of the maximum shunted flow. The arrow is pointing to the position of the sample volume. This will again demonstrate the characteristic spectral as well as the audio signals of the left-to-right shunt across the ASD. The characteristic spectral profile is shown in this still frame. The left-to-right shunt commences in late systole and is holodiastolic in timing, and there is further accentuation of the shunt across the atrial septum following the atrial contraction. Note again that the turbulent nature of this flow across the atrial septal defect. In real time, also appreciate the characteristic audio signal of this left-to-right shunt. Now we are demonstrating the continuous wave Doppler examination of the tricuspid regurgitation in this patient. Note high velocity tricuspid regurgitant jet measuring 3.8 meters per second. Now watch this in real time. This high velocity jet indicates presence of modest pulmonary hypertension, which will be further discussed later on. Now we will demonstrate the utility of transesophageal echocardiography in visualization of ASDs in 2 patients in whom standard 2D echo examination failed to visualize the defect. This is the still frame of a 20-year-old patient undergoing transesophageal echocardiography. This is the left atrium, atrial septum, right atrium. The ventricles are off this particular image. Note the clear visualization of the entire atrial septum, and this very small 3 to 4 millimeter size secundum atrial septal defect can be clearly visualized in this still frame. In the color flow mode, this small jet of left to right shunt can be clearly visualized. Note that we are utilizing the conventional flow map with flow away from the transducer encoded in shades of blue. Hence, this left to right shunt will be visualized in shades of blue coming through this small atrial septal defect. In real time, you can clearly appreciate the small jet of left to right shunt across the small defect. This next example is the transesophageal echocardiographic examination of a 34-year-old female. This is left atrium, mitral valve here. This is the tricuspid valve, dilated right ventricle, and note the dilated right atrium. The defect in the mid portion of the atrial septum can be clearly visualized. Note that the lower portion of the atrial septum as well as the uppermost portion of the atrial septum is intact. In real time, you can see the defect clearly as well as the margins of the fossa ovalis membrane. In color flow mode, you can clearly visualize this large bolus of flow going across the atrial septal defect. You can see this vividly also in real time, and the shunt is represented in shades of blue. Now we will discuss ostium primum atrial septal defect. In this pathology slide, we are looking into the open right atrium and right ventricle. Note the right ventricle is dilated and hypertrophied. The typical location of ostium primum atrial septal defect in the lower portion of the atrial septum can be clearly seen. Here is the limbus fossa ovalis with intact fossa ovalis membrane. This is the location of coronary sinus. Also note that the inferior margin of this ostium primum atrial septal defect is formed by the plane of the atrioventricular valves. This is the same heart specimen. We are looking into the opened left atrium and left ventricle. The atrial septal defect in the lower portion of the atrial septum is again clearly seen. Pay attention to the mitral valve. Note the anterior leaflet of mitral valve has a large cleft extending all the way to the base. The cleft in the anterior mitral leaflet is almost always present in patients with ostium primum atrial septal defect and is part and parcel of partial atrioventricular canal defect. This is the 2D echo examination of an 81-year-old patient who is the oldest patient with partial atrioventricular canal defect that we have seen. In this long axis view, note that the right ventricular cavity is markedly dilated, left ventricular dimensions are normal, the mitral apparatus is somewhat unusually oriented into the left ventricle, and this will be better appreciated in real time. The left ventricular outflow tract is normal and left atrium is moderately enlarged. In real time, you can see the features of right ventricular volume overload. Note the abnormal orientation of mitral apparatus and the dilated left atrium. We are now looking at the peristernal short axis view of the mitral valve. Here we are demonstrating the cleft in the anterior mitral leaflet. The cleft divides this leaflet into two nearly equal halves, the medial component and the lateral component. This can be well appreciated in real time. Let us look again at a short axis scan. Note that the interpapillary muscle distance is reduced, and as the scan is extended cephalad, the typical cleft in the anterior mitral leaflet can be visualized. At the base of the heart, sclerotic changes of the aortic valve are evident, and the atrial septal defect cannot be clearly visualized. We are now looking at the four-chamber view. In this image presentation, the apex is oriented on the top, the right-sided chambers are on the right, and the left-sided chambers are seen here. Note that the right ventricle and the right atrium are markedly dilated. The defect in the lower portion of the atrial septum can be very clearly visualized. Another characteristic feature is shown here. Note that both atrioventricular valves insert at the same plane at the crest of the ventricular septum. Further note that there is no ventricular septal defect evident. In real time, note marked dilatation of right ventricle, normal size and function of left ventricle, insertion of both AV valves at the crest of the ventricular septum at the same level, large ostium primum atrial septal defect, and incidentally noted is a large eustachian valve in this position as well. This next example is the transesophageal echocardiographic examination of a 39-year-old patient. This patient had a poor quality transthoracic study because of marked obesity. In this view, the left atrium and left ventricle are here, right ventricle and right atrium in this position. Note this large ostium primum atrial septal defect is clearly visualized. Both mitral and tricuspid leaflets insert at the same level at the crest of the ventricular septum. In real time, you can appreciate the high-resolution image of the atrial septum and of the primum atrial septal defect. In this color flow mode, note that a large shunt can be seen passing from left atrium through this lower portion of the atrial septal defect into the right atrium. Note that we have changed the color map. Now the flow directed away from the transducer is encoded in shades of red. Hence, in this particular example, the shunted flow is seen in shades of red. In real time, you will appreciate the shunt more vividly. The least common variety of atrial septal defect is the sinus venosus type. In this path specimen, we are looking into an open right atrium and right ventricle. For orientation, this is the tricuspid valve, and here is the orifice of coronary sinus. This is the limbus of fossa ovalis with intact fossa ovalis membrane. Note the location of this sinus venosus atrial septal defect being superior and somewhat posterior to the limbus fossa ovalis. Here are the anomalously connected pulmonary veins from the right lung. Remember that anomalous pulmonary venous connection is almost always present in patients with sinus venosus atrial septal defect. 2D imaging of sinus venosus ASD is frequently very challenging and requires scanning in the frontal plane from the subcostal position. This still frame is that of a 36-year-old patient with sinus venosus ASD. We are looking at the crest of the atrial septum. Note clear visualization of this large sinus venosus ASD. The thin membrane of fossa ovalis is intact, and so is the lower portion of the atrial septum. Note in this position is the anomalous connection of right pulmonary vein joining the right atrium at the atriocaval junction. The defect is also clearly visualized in real time. This is the still frame of color flow examination. You can clearly see a large bolus of red encoded flow coming through the atrial septal defect and entering into the right atrium. You'll see this also quite vividly with real-time examination. This is the transesophageal echocardiographic examination of another patient, age 57-year-old. We are looking at the left atrium, atrial septum, and right atrium. Note this patient has sinus venosus ASD, which is clearly visualized on this examination, while this defect could not be visualized from the standard precordial and subcostal examinations. You can visualize this defect in real time now. Color flow mapping shows a large bolus of shunt from left atrium to right atrium. The echocardiographic diagnosis of partial anomalous pulmonary venous connection remains challenging. However, the diagnostic accuracy of echocardiography has been markedly improved by addition of color flow imaging. This still frame is from a patient who has partial anomalous connection with intact atrial septum. This is a right parasternal view with right atrium, atrial septum, and left atrium visualized in these planes. In real time, you'll note that the atrial septum is intact. Color flow mapping confirmed that the atrial septum was intact, and in real time, as we scanned the free wall of right atrium, the anomalous connection of the right pulmonary vein directly to right atrium could be clearly visualized. This is the magnified view demonstrating again very nicely the anomalous connection of pulmonary vein directly to right atrium. Having established diagnosis, next it is important to determine the hemodynamic severity of the shunt lesion. In general, the magnitude of shunt can be readily established by visualizing the width of the color flow jet. In this tape, you have already seen examples of small as well as large shunts. In our practice, we infrequently calculate the pulmonic and systemic flow ratios. The technique and the formula utilized for this calculation has been illustrated on previous tapes. We routinely, however, will calculate right ventricular and pulmonary artery systolic pressure utilizing continuous wave Doppler. In the example that was shown earlier, the elderly patient with atrial septal defect had tricuspid regurgitant jet velocity of 3.8 meters per second. Using the simplified Bernoulli equation, this calculates to a 58 millimeter mercury pressure drop from right ventricle to right atrium. The right atrial pressure in this patient was estimated as 12 millimeters mercury. Therefore, the calculated right ventricular and hence pulmonary artery systolic pressure equals 70 millimeter mercury. During the time of this hemodynamic assessment, patient's blood pressure was 120/70 millimeters mercury.